So our next speaker is Dr. Zachary Kerr. He's an assistant professor in the Department of Exercise and Sports Science at the University of North Carolina at Chapel Hill. He serves as the research director for the Center for the Study of Retired Athletes and core faculty for the UNC Injury Prevention Research Center and the Matthew Gefeller Sports-Related Traumatic Brain Injury Research Center. As we were prepping for today, Zach sent me a private email and he wanted me to add into his introduction that as an alum from the, all capital, Ohio State University, who bleeds scarlet and gray, he's honored to work with faculty and students on a number of projects that highlight the collaboration and dialogue can transcend even the silliest of sports rivalries. Welcome, Dr. Kerr.
All right, you're going to get this once and once only. There's only one other time I've ever worn Michigan gear, and that's the one time in the last 20 years you actually beat us in the big game. So here's your moment. There we go. We're done. Where's the pointer? This is the pointer? Is this is a pointer? This is the Ohio State University education right here in full motion. But thank you all for having me. I was joking with Steve that, I'm in enemy territory, but this is a really great college town, and it's really awesome to see everyone with their school spirit and their gold and blue, or maize and blue, whatever. Okay, I'll stop with the Michigan jokes at this point. But I just want to describe, I do bleed scarlet and gray. I did 2 masters there at Ohio State. But really, I wasn't that great of a fan because every time the big game happened, that's when I went and did laundry because no lines, I'm going to get stuff done. But I'm going to talk today about the exciting topic of epidemiology. And epidemiology, I know, is kind of a topic that scares a lot of people, but my hope with these slides and this presentation is that it's able to help make things a little bit more understandable and less scary for you all. And I should note that when I first created these slides, the presentation was actually about an hour long, so I cut some slides out, but I did leave a lot of the slides in your take-home packet. So if you're following along on what was provided to you and you see some slides don't match up, that's why there's some information that I felt I couldn't get in 30 minutes, but I still felt was important for you all to get. So please, if there are any questions about any of those supplemental slides, let's talk as well. Epidemiology is the study of the incidence, distribution, prevention of diseases and other factors related to health. The field of sports injury epidemiology is quite still in its infancy in the sense that when we think of epidemiology, we think of diseases such as cancer or cardiovascular disease. And there are other outcomes we have to think about, such as sports injuries, including concussions. And going back to 1992, researcher Willem van Mechelen created the sequence of prevention framework. And for me, this framework for sports injury prevention really works well with our thoughts about injury epidemiology. You have to look at the who, what, where, and when, the surveillance of what's on the landscape. So what is the current state of the incidence of concussion? You have to identify risk factors, and then you have to develop prevention mechanisms that then can be looked over longitudinally in time. So other talks today are going to talk about the bottom 2 aspects, and I really want to focus on surveillance, on what is the current state of the incidence of concussions in the sports world. And I talk about injury epidemiology sort of being a little bit younger than other fields supposedly are perceived to be like that, but sports injury surveillance has actually been around for nearly 100 years. It really started with secondary data collection initiated in the 1930s through organizations such as the National Center for Catastrophic Sports Injury Research. And a lot of our stable systems that we know and love for sports injury surveillance really come from the NAIRS system, the National Athletic Injury Reporting System, which was created by Kenneth S. Clark and other individuals. And there's a great journal article that I have on the bottom here from 1976 that talks about the premises and pitfalls of athletic injury surveillance. And some of those issues that he talked about back in the 70s still exist today as we try to continue perfecting and making the surveillance better. But as you see on the right side, there are numerous information systems available at the general public level to the professional, collegiate, high school, and we are starting to see a middle school surveillance system in its infancy, beginning its 4th year. But the general methodology of many of these systems is it's a convenient sample. In many cases, we're trying to obtain a census, all data possible, but sometimes that's not possible. We have to just go with those schools that are willing to provide information for us. And a lot of people kind of take a glass half empty approach saying this is not generalizable. I know when I worked at the NCAA, I always had one football coach or one coach from another sport saying, well, this doesn't represent my team. I don't care if you have all but my team. Your data doesn't represent me. And my challenge to them was always, well, sign your team up. So if you are working with high schools, you are working with collegiate programs and are interested in contributing to the general knowledge that can be used by researchers and development and policy programmers, please do consider participating in one of these surveillance system programs. With that said, we utilize athletic trainers for the most part to attend the practices and games as part of their clinical practice, and then they track injuries and exposures. And an exposure that is used many times in surveillance in the United States is called an athlete exposure, which is a head count of all participating athletes in each game and each practice, and that's summed up collectively over time to give us the athlete exposure count. And through collection of the data, the athletic trainers are also getting detailed information on the injury characteristics. And athletic trainers, how many athletic trainers are in the room? Okay, so I've always said for many years that I feel that athletic trainers are very much the gold standard of data collection for surveillance. You have the expertise, you have continuing education, and a lot of times there's been some criticism of the use of athletic trainers, and the great thing is that you're seeing research coming out showing that athletic trainers are very good, reliable, valid sources of data collection. So big up to the athletic trainers in this room. Oh, I forgot about, so you won't find this in your slide. So this meme of this pit bull was meant to say that this is confusing, but my hope is that by the end of this talk, you won't be making that face. That would have been better had I remembered that slide was there. Any excuse to put a dog in for me, if it's not, research, it's puppies for me. But a concussion rate, moving on, awkwardly, concussion rate is really based upon two things, these counts of injuries and these counts of exposures. And it's a combination of looking at the summation of concussions divided by the summation of athlete exposures. So as noted, we talked about the definitions for both the concussions and the athlete exposures, both of which are focused on those occurring in games and practices. But let's say we had a football team with 100 players and they had 10 preseason practices each. And during those 10 preseason practices, those 100 players participating in all 10 preseason practices had a total of 5 concussions sustained. The rate would be 5 over 10 times 100, which would give you 5 concussions per 1,000 athlete exposures. And we utilize this common denominator, in this case 1,000 or 10,000 athlete exposures, to help with that comparability, to understand despite the variations in at-risk exposure time, we can kind of look at this rate on an even playing field. Because when we look at injury rate ratios, we want to be able to make a comparison and talk about that effect estimate. So how much does one rate vary from another rate? So if we have two teams and we have team A, which had 5 concussions per 1,000 athlete exposures, and another team that had 2 concussions per 1,000 athlete exposures, our injury rate ratio is pretty much just one rate divided by the second rate. So in this case, the rate ratio would be 2.5. In other words, rate A is 2.5 times that of rate B. All right. So now that I've given you a rundown about Epi 101, or Surveillance 101, and the calculation of injury rates and injury rate ratios, I want to move into some of the actual data we have. And so on all my slides, I have in the bottom right the actual data source. If you have trouble finding those data sources, please do not hesitate to email me or talk to me, and I can help you obtain those data as well. But the NCAA concussion rates, this actually came through the work of myself and colleagues from UNC Chapel Hill and Vanderbilt University. Scott Zuckerman, who is a neurosurgeon fellow there, was really interested in looking at data from the NCAA level. We worked and collaborated, and these data are a bit slightly about 5 years old, but you can see that the contact sports do have the highest concussion rates. And for those of us who work in this field, we know this is a pretty standard thing. But the interesting thing in these data was that we found that the wrestling rate was actually higher than that of the football rate. And this is where convenience samples come into play. I wouldn't say with these data that wrestling has the highest rate of concussion. I would say that wrestling has one of the highest rates of concussion, but you can't ignore the fact that ice hockey and football also have high rates of concussions. And if you actually look at the more recent or longer periods of data, you'll find that those differences between the contact sports do level out, and you don't see such as high of a concussion rate wrestling-wise compared to the other sports. So do keep that in mind about time periods do play a role in the data that you're seeing. So again, to go back to the injury rate ratio, if we take men's and women's soccer from the NCAA level and we compare those rates, we have a rate ratio of 1.83. In other words, the women's soccer rate is 1.83 times that of the men's soccer rate. Or you'll hear individuals say things like the women's soccer rate is 83% higher than the men's soccer rate. And we do see that systematically across many of the sports that are what we consider to be sex comparable. Now, I do include ice hockey. There is an argument that men's and women's ice hockey is not sex comparable, but I wanted to show the insignificant injury rate ratio there to kind of relay that point that we are seeing sex comparable differences in those sports, but only within certain sports such as the basketballs, the soccers, and then the baseball versus softball. So High School Rio is a data system that has been in existence since 2005, and many people know the Malika Morar paper that was published in AJSM in 2012. Fun fact, when she wrote that paper, she was actually a high school student. So one of the top cited injury surveillance papers in the field of sports injury epidemiology was led by a high school student. Imagine that. And she is incredible still. I went and Google searched her, and she is, I believe, finishing up her residency in an institution, a university institution. But being that this data are older, I wanted to look at updating it. So Don Comstock and our team looked at data from 2013-14 to 2017-18, and we did find a lot of similarities from the data that Malika led analyses on, but we did find that the rates were slightly higher than they were during the era of 2009-2010 that Malika et al., Morar et al., looked at as well. And I think part of that has to show the changes in concussions, the change in diagnosis tools that help us get a better sense of detecting better our concussion incidents that's occurring within our populations. And likewise, we're seeing the increases in incidents. But once again, we're seeing that the girls' sports do have higher rates than the boys' sports. So this is some interesting data from the American Journal of Preventive Medicine using middle schools achieves data coming from the state of Virginia, where Shane Caswell and his team from George Mason University are leading outreach for athletic training services in the area of south of Washington, D.C. And Shane has been doing this work for the past 3 or 4 years. And the school district is so in love with these data that actually many administrators were not willing to take raises that they should have received in order to fund athletic trainers to be there. So these data are from 9 middle schools that were provided athletic training services by 9 AT master's students from George Mason University. And this upcoming school year, they're actually expanding it to 16 schools. So that's an incredible story about public health and the benefits and the value of athletic training. But when we look at the middle school data, 2.61 per 1,000 athlete exposures, the football concussion rate is much higher than we see compared to the other sports. But once again, we're seeing that trend again, that the injury rates for concussions in the girls' sports are higher than that for the boys' sports. Another thing I should note is that within these data set, which aren't included in these rates, about 1/3 of all concussions, those 1/3 not being included in these data here that you're seeing, were from non-sport related activities. This is one study, though, looking at 2 years of data. I think actually this is 1 year of data, but we need more data from these smaller youth levels. And we do have a lot of data from youth leagues, recreational sports, competitive sports clubs at the youth level. Here are a couple that I was able to pull out. But the reality of it is that the middle school setting is so different from the club sports setting. Many cases, and some of the research that myself and my co-PI for our CDC funded study, John Regis Mihalik and I, we found that the culture and what people perceive middle school sports are compared to youth club sports is very different. In reality, middle school sports is sort of an after-school service that parents can use to have their kids in a safe environment and also get physical activity. And once a concussion or an injury happens, mom and dad do not feel comfortable and pull them out. So it's much harder to work in those middle school sports settings than it is to work in those club sports settings. And there's different knowledge and attitudes and a lot of great work being funded by the CDC to look at this phenomena and how it differs in middle school sports versus club sports. So we do need more data amongst the youth level, but particularly within middle school sports. Another thing I do want to note is sometimes we focus so much on the fact that concussion rates are typically higher in competitions than they are in practices. But remember that practices are controlled environments. We have practices, we have skill development, and we can't ignore the fact that concussions, a good proportion of them, in many cases 1/3 are in the middle school setting, as we see here, 2/3 happen within those practice settings. So interventions have to occur within competitions as much as they have to occur in practices. Now, this is some data that we're working on in progress right now for the Journal of Athletic Training being led by Jenny Hootman from the CDC. And we wanted to look at the trends. And we've talked about how there's this increasing trend in concussions over the past few years, given the legislation and the better diagnosis tools. But it's very different from what we're seeing with other injuries, such as ankle sprains here, which is the thick black line. The rates of ankle sprains have gone down consistently over time, but we're sort of in this place now where we saw for the last few years increases in concussion incidents, the rates at least. But what we're finding, at least with the high school Rio data, is that it's now at a standstill when you look at the overall rates, that the rates are actually staying pretty stagnant. And maybe we've reached this level where the amount of concerns we had about disclosure or reporting have been mitigated or at least minimized to a point. But the other thing we have to consider is that overall concussion rates are inclusive of both competitions and practice. So we have to think about both of those side by side. And what we're noticing, at least with the high school Rio data as of the past 5 years, is that the competition concussion rates are actually increasing in football, but they're decreasing in practices. And we're finding that in other sports, when we try to combine them by different types of classifications, as you can see here by these figures, that this phenomenon is only occurring, according to these data, within football. So we have a lot of triumphs that we can see with practices and the mitigation of contacts in practices, but we still continually have to think about what's going on in the competitions as well. The other thing that has been shown through some of the research by Ginger Yang, the American Journal of Public Health, and we see it in our own data analyses as well, when we're talking about recurrent sports-related concussions, this is inclusive of practices and competitions, we have seen decreases in the incidence or the rate of recurrent concussions over time. And typically, those decreases can range from 0.13 to 0.02 per 10,000 athlete exposures. There may be an argument whether or not that's clinically meaningful, but I think this is, again, evidence that the work that has been done to ensure healthy return to play, to ensure that athletes are getting the treatment and the management that they're needing, is helping to mitigate the risk of occurrence of a recurrent concussion. So symptomology, many of you will see these slides or hear people talk about it. You know, these are pretty standard knowledge, but headache, dizziness, difficulty concentrating across the board for NCAA sports, high school sports, youth football studies have found that these type of symptoms are pretty common across all different individuals and all different sports. But once again, as we look at time trends, looking at the work of Dustin Curry and Don Comstock, that as we look at trends over time, these types of symptoms as they appear have been changing slightly. For example, they found in their high school Rio data that the incidence or the prevalence, of amnesia, loss of consciousness has gone down, while the reporting prevalence of drowsiness, irritability, light sensitivity, noise sensitivity has gone up. And they argue that, once again, this is showing a change in our knowledge about symptomology. It's not anymore that you have to have loss of consciousness or amnesia for it to be diagnosed as a concussion. There are other symptoms and other ways to keep in check what sort of things could be at play that may be related or associated with a concussion. Another trend that Don and I have talked about for many years is the return to play. And across time, the number of individuals who have been returned within a week has gone down. And we see it with the high school Rio data. We see it with the NCAA data based upon the work of Aaron Wasserman looking at concussion symptomology from 2009-10 to 2013-14. The one slide that I think is in your notes but isn't in this slide is that looking at the high school Rio data from the past 5 years, we see pretty much a standstill, a threshold reached where there's no change across time. So I think we have seen these great changes within the past 10 years, and we're starting to see it become a standard practice now. And I think it's another sign of the great management and care that sports medicine staff and athletic trainers are providing to their clientele. So what do we know? We know that contact sports typically have higher concussion rates. Typically football, but other sports have high rates as well. Female rates are higher than male rates. Competition rates are higher than practice rates, and there are changes across time. So do keep in mind when you're looking at the older data that there are differences back then in practices, differences in reporting and methodologies that may play roles in being able to generalize the data to the individuals that you are working with today. So I'm talking about how great concussion surveillance research is, but there are limitations that I think we have to talk about. So rates. It's easy for me as an epidemiologist to talk about the number of events that are occurring within a specific time frame, but we always joke that rates are there to brag to other people that we can do long division. And in the reality, a lot of people do not understand how non-intuitive injury rates are. So if we're looking at that NCAA data, and I showed someone this slide, they may say that, well, wrestling is really the sport we have to watch out for. But if I frame the data in a different sense, and we have this in the Zuckerman paper where we show the national estimates of data, so these aren't rates, these are estimated actual frequencies that are occurring. 1/3 of all concussions we estimate are occurring from football. And when you look at ice hockey and wrestling, they're only accounting for about 10% of the data we're looking at. So how you shape the data and how you present the data can really tell two different stories. And you are telling the truth as we know it based upon our data, but we have to think about how we report our data as well. At the same time, it's easy for me to say, well, across 10,000 college football athlete exposures, we expect to see 6 to 7 concussions reported. But despite that, it's still very hard to talk to journalists, to talk to policymakers, parents, and coaches, and understanding what's the risk, what's the probability that my kid will get injured. And there are different ways we can talk about this. We can talk about this maybe by cutting that NCAA data in many different ways. We can talk about the average number of concussions per team per season. And if we cut the NCAA data like that from back in 2011-12 to 2014-15, wrestling's not the culprit anymore. Now it's football. But I know many athletic trainers will say that in a college sport such as football, to only see 5 to 6 concussions within one season, that's ridiculous. That's what we get in the preseason alone. So data that we get from surveillance, valid, I feel very comfortable and confident with, but we have to remember there are limitations nonetheless with those, particularly with the issue of non-disclosure, where we talk about 50% of all concussions may go unreported, and that's why we have tactics and strategies being led by institutions such as the NCAA to help us understand how to help athletes better disclose their concussion injuries to sports medicine professionals. At the same time, rates are great for us in sports injury because we're able to account for the variations in evidence of event incidence and exposure per person. But is it always easy to get exposure time so easily? And Kathleen Baginski and David Swedler brought up this point in a commentary to the American Journal of Public Health when they were looking at how playground injuries were only telling part of the story when you couldn't account for at-risk exposure time. So they were arguing that, as great as it is that we got risk, that we got incidence and frequencies, that we should be trying to get at-risk exposure time for those kids playing on the playground. And the authors came back and said, this is great, we agree. How do you collect playground exposure time? And I know a person from UNC who said, I had a friend who tried to do that, and then the cops were called on him because he looked like he was creeping on little kids. So easier said than done. But this is important because how we present data and how data are presented to our stakeholders really can change the way that how parents perceive injury risk and perhaps how likely it is for parents to let their children play sports. and how organizations present the data, they are aware of this, and it's important that we think carefully about why the data are presenting in the way they are. And not all research is created equal. I have a shameless plug, I apologize, but I did have the opportunity a couple years ago to work with many experts in the field who work with sports injury surveillance, who have for many years, and we wanted to talk about some of these issues, and some of them I have talked about today, but do check out this article in Neurologic Clinics. We kind of detail a lot of things that I wasn't able to cover in this talk as well. But as much as I want to be critical of sports injury surveillance, I think there are great strengths. And looking back to the sequence of prevention framework, surveillance has helped us look at the benefits of interventions meant to prevent and better manage concussions. And there are many countermeasures that exist. There are so many here, and this is just an excuse to push a button multiple times. But with the right resources, I think some of these could be evaluated by surveillance. And I have looked at USA Heads Up Football. I have looked at Pop Warner practice contact restrictions, but there's not much research out there showing evidence of the effectiveness of Heads Up Football besides some of the work I've done. And I always encourage researchers to say, if there are flaws you see in studies, whether it's my studies or anyone else's study, please try to find ways to replicate the study to help either strengthen the implications that I've made, or on the other hand, weaken them. And if they are really good studies, then I'm going to be the first person to say, you know what, that is a much better study, and I am very happy that you've done this, and I feel that your data is probably more valid or reliable than mine. Because as a researcher, I feel that if I'm not looking back at my old research and saying, man, I could have done that better, I'm not growing as an individual, I'm not growing as a person. And so I love the fact when there are young researchers, how many of y'all are students in here? I mean, okay, there's a couple, but you're the next, we're gonna be dead in the dust in a couple years. You all are the future. Like Whitney Houston said, oh, sorry, this is why Steve Broglio said, keep it professional, because he was looking at me when he said that. But in the words of Whitney Houston, I believe the children are the future, and I think there's much importance in us as mentors, providing them that opportunity to challenge us and think differently. But we need surveillance to help us understand concussions. And there are a lot of great studies out there. In a second, you're going to hear from Doug Wiebe, who's a superstar in injury epidemiology, and he's going to tell you about the great things being done by the Ivy League Big Ten concussion surveillance program. But when we think about it from a public health sense, I have to have a public health slide, being an epidemiologist. When we think of Haddon's countermeasures, we think about how do we best look at prevention that is feasible as well as effective. And we can do the most extreme things to more tertiary management of those who are already inflicted. And if we're talking about banning youth sports, we are going straight to the most extreme thing. And that scares me because there's all these other prevention potential that exists out there. And we have to capitalize on that. We have to capitalize on what sort of resources and strategies we have as researchers and clinicians and practitioners to help ensure that we are giving some of these prevention strategies a chance. And more importantly, when we show that an injury prevention works, we do not end there. We do not sashay away and say, we've done everything we needed to, moving on. Someone please tell me where this is from. Thank you. First symposium where someone has figured out where this is from. Thank you. Jade, cycle 6 or 7. Great. Yeah, spirit, she's my spirit animal. Thank you. We're going to chat after this. Yeah. Thank you. You don't know, all the time I have blank faces and people are like, I was like, come on, you all have lives outside of, no one watches CW, want to be on top? Nope, okay, nope. All right. But implementation alone does not lead to meaningful change. One study in a scientific ideal setting does not change the world for everyone else, because what you see in our backyards, in our college campuses may not work in rural areas, lower socioeconomic status areas, and the next step is thinking about how do we implement these so everyone prospers from it? How do we implement these so we can identify barriers and facilitators and mitigate those barriers and help ensure that those facilitators are present so everyone can prosper from these interventions? So future directions, thinking about the epidemiology of concussion, we need to continue supporting surveillance to help us understand the who, what, where, and when. but we can't overask. Surveillance can give us the tip of the iceberg, the stepping stone. We need those more in-depth etiological studies that can help us identify risk factors. And working together, we can really help ensure that the cycle of the injury prevention sequence that Van Mechelen proposed back 20, 30 years ago is going to come to fruition. And I think I made a hint of it, but we really need to help the underserved. And in many aspects of public health, we talk about pro-equity research. And I think we're starting to realize that now in our field, and we're starting to talk about it more. How to ensure that our research, our practice, our care helps everyone, and not just those who are already within places of privilege. So with that said, I have a minute left, and I did that on purpose. The other thing I want to talk about is support. I could not do this without a group of people who I love, who care for me, who I care about, and they are my support system. If anyone knows hashtag Cry and Cut, it's from Project Runway Season 2. Zulema said it to her teammate who was crying, and she said, I don't care if you cry, but you better keep crying and cutting. And Kara was like, but that's how I say it sometimes. Sometimes I feel down, I get hard on myself, and my friends are like, cry and cut, get it done. But I do want to take the last 30 seconds to say, 5 years ago, I was at a meeting and someone looked me in my face and said, I hope you don't mind me sharing this story, Steve. Someone looked at me dead in my face and said, who's to say you're going to be around in 5 years? And there's one person in that room who stood up and defended me, and he didn't even realize that. But I had that date on my calendar, May 17th, 2014, and on May 17th, 2019, I think it was a Saturday morning, I called the person and told him thank you, and that person was Steve Broglio. I don't know what I would have done at that point if he wasn't in that room to help defend me. And I wish I had the balls now that I do to maybe talk back or pop off to that researcher. But back then I was new to the game, just out of my Ph.D., and it was good to have someone who was watching out for me. So thank you, Steve, and thank you everyone for your help.